technical difficulties, but I'm figuring it out. Share. Okay, here we go. All right, welcome to Add-on Psychotherapy webinar. We are super excited to talk with you guys about this today. Make sure to stay until the end to hear about the bonus offer that we have for you guys. We're very excited about that as well. You guys already dropped your location in the chat. You guys pretty much know who I am. I think I'm Lindsay Hilm, psychiatric nurse practitioner. I've been practicing for 10 years now, and I'm really passionate about brief psychotherapy because a lot of us didn't feel like we got enough training on it in school. And I've also seen the outcomes that with our patients that we can have when we are skilled at brief psychotherapy. So just a couple quick housekeeping things. The recording will be sent after, so if you can't attend live, no worries. If you could submit your questions in the Q&A section, we're going to try to answer some of those at the end. And like I said, stay until the end and just chat it up in the chat section. So some of you might know this, but I did my doctoral project on dialectical behavior therapy. That being said, at my first job, if they had told me you need to start billing for brief psychotherapy along with medication management, I would have panicked because I was already extremely overwhelmed just with thinking about doing med management. And so even though I had learned different therapy techniques in school, it doesn't mean that I was feeling confident enough to implement those. And that created a lot of stress for me. And that's part of why I'm so passionate about Dr. Debbie's content, is because it makes brief psychotherapy and med management so actionable. And I went to trainings. I would spend thousands of dollars on some of the trainings that I went to get more therapy skills. And it would be great. I remember I went to one, it was David Burns, Dr. David Burns, Feeling Good. But I would come back to my 20-minute, 30-minute med checks and be dealing with, co-occurring diagnoses, polysubstance use, and I didn't quite know how to implement what I had learned, practically speaking. So I don't know if you put an emoji in the chat if you can kind of relate to that. So that's why I'm so excited to have Dr. Debbie Granick with us, also known as the 20-Minute Therapist. She is working on a book right now that's not released, but I'm super excited about that because that's another thing. I felt like the resources I was given in school didn't necessarily tell me what to do or how to do it. She is very passionate about this. Her master class on brief psychotherapy add-on was her doctoral project, and it's helped so many people. People have such great things to say. It's so value packed. When I found it, I was like, where was this when I was in school? This would have been a game changer. She's from North Carolina, and she is just so great at, again, practical ideas of what you should actually say when you're with patients. So thank you for being here, Dr. Granick, and I'm going to pass it over to her and stop sharing my screen.
Great. Thank you. It's so great to be here with you guys. And like Lindsay said, this is really my passion. I'll introduce just my background briefly, and then we're going to get into, how do you do this? But basically, in the early 90s, got an MSW MPH degree. I was interested in social work, but kind of in a health space. And I practiced as a therapist for quite a while until I started feeling like a lot of health issues were what people were coming to therapy about, right? Either it could have been, postpartum depression. It could have been they just had a diagnosis of diabetes. It could have been a teenager with depression, but there seemed like a biologic component, like that something more was needed besides just therapy. So I actually, when my youngest of three kids, who's now 22, when they went to preschool, I went back to community college to take some prereqs for nursing school, and then ended up doing an accelerated bachelor's of nursing and becoming a psychiatric nurse practitioner. Because what I really wanted to be able to provide was integrated care. I hated that our system was so fragmented that people were going to therapy with one person and medication only with another person. So, and then, yes, as Lindsay said, then I became really interested in how do we train and equip prescribers, I hate that term, but for lack of a better term, to feel more comfortable and skilled providing a little bit of therapy, not necessarily to become Freud. But as you all have probably heard from many of your patients, sometimes someone will go to a psychiatrist, an NP, a PA, and then come in and say, it was a 6 minute visit. There was a 2 minute visit. They just like asked me if my Prozac was fine, and that was it. And it breaks my heart when that happens because this person has potentially taken 3 buses and 2 trains to get to your office, unpaid time off work. Maybe they have a kid in tow, like who, with daycare, whatever. Why shouldn't we be providing the very best that our scope of practice allows us to provide? Which, as we know, therapists can't cross over to medication, but we can cross over to a little bit of therapy. It is pretty unquestionable in the research that the combination of therapy and medication is what gets people better, faster, and for longer. So it's a it's allowed, it's in all of our scope of practice, it's best for our patients, and it actually is really advantageous to our practices as well. The underbelly, I feel like kind of the dark underbelly of this world of mental health is like no one wants to talk about money. It feels like inappropriate to be talking about money, but the bottom line is getting paid for what we do is very tied to keeping us in this field and keeping us from burning out. So if you are providing a higher complexity service, if you're helping people with multiple modalities and approaches to care, you should be compensated. And we were talking just before this started about kind of average compensation for a 90833 is about $75, which means that, even if you buy this course at the end, you can pay for that in 6 or 7 uses of this add-on psychotherapy code. And that's what we want. We want you to feel at the end of tonight that you can access a program that will help you, stay in your practice, keep from burning out, feel more motivated, feel more skilled, and that pays for itself, right? That makes it worth your time. So that's kind of where I come from in terms of my approach. And without further ado, I have 5 million slides. I know I won't get through all of them, but I wanted to go through and help you guys feel like you understand a few basic approaches of multiple kinds of therapy and when and how to use them. And then we can take more questions in the Q&A. I lead with this. Therapeutic alliance is still the biggest predictor of outcome. The reason this is important is not that it's not important to understand CBT, to know the concept of thought distortions, to understand radical acceptance as an approach within DBT. Yes, we do need certain skills, but those skills alone are worthless to our clients. We need that therapeutic alliance and connection, and that is your genuine self. It's bringing yourself to show up, especially in like with clients who are more marginalized, higher risk client populations. The degree to which you are genuine, caring, compassionate, accepting has even more positive outcome. And actually, if you don't show those things, has even more risk of negative outcome. So I say this because yes, you need some skill, but even if in the middle of trying to do CBT, you end up saying, I'm so sorry. I know there's a name for this distortion that I'm hearing you say a lot. I'm not remembering what it's called. And I'm sorry for that. I can look it up. But I'm hearing a lot of negative ways of seeing the world from you. And I wonder if that's your kind of habit and if that maybe is keeping you stuck, right? So I messed up. I didn't know the name of the thing, but I approached it with genuineness and caring and concern for this person. And that's going to probably matter more than that I couldn't remember the name of black and white thinking, right? So I think that's really important.
Real quick, Debbie.
Yes.
Someone is asking if you wouldn't mind putting the PowerPoint on presenter view.
So the reason I wasn't doing that is because I feel like I'm going to have to skip through to different slides and I wanted to be able to see
Gotcha.
where they were, but I can do that. I'll just do it. Okay. Okay. So am I on presenter view now, I think? or no?
Not yet.
Hold on. You know what? It doesn't want to do that. I don't know why. Okay. Um, so hopefully you can still see it okay, because I just wanted to be prepared to be able to skip around to a few slides. So also is, what is psychotherapy, right? Sometimes I feel like we might get kind of caught up in um, feeling like it's something necessarily super complex. No, psychotherapy says you are trying to affect change through the provision of therapeutic communication. Yes, there's all these different techniques, ACT, DBT, CBT, MI, right? But it is psychotherapy if you are trying to treat an emotional disturbance, some kind of, behavior that's not working for the person, encourage growth, encourage development, you're providing psychotherapy. The time that add-on psychotherapy is not an appropriate modality would be if you're working with someone who's not verbal, if you're working with a really young child, if you're working with someone with advanced dementia, if you're working with someone with significant developmental delay. It has to be someone for whom verbal therapy is appropriate. That's so as long as you're within those guidelines, you're probably good. Let's start with a couple nuts and bolts of what is add-on psychotherapy. So, add-on psychotherapy, by definition, means that you are providing therapy in addition to an E&M service on the same date of visit. So, if it's separated by, the next day or whatever, not add-on psychotherapy. It means that there's two services provided within one visit. To constitute add-on psychotherapy, the psychotherapeutic service itself is supposed to be a minimum of 16 minutes. The 90833 add-on code, which is the most commonly used one for us because most of us just have about 30 minutes for a visit, is 16 to 37 minutes. Then they're coded up like a 90836 is 37 to 53 minutes, but most of us aren't using that too much. And the add-on psychotherapy part needs to be separate and identifiable. So if I'm extremely therapeutic and kind and gentle and inquisitive and, ask a lot of open-ended questions for 25 minutes, trying to help someone figure out whether they'd rather be on Depakote or lithium for their bipolar disorder, that is not add-on psychotherapy because the focus was on medication management. So the time of the visit does not dictate whether or not you did add-on psychotherapy. What dictates whether you did add-on psychotherapy was whether this therapy was a separate and identifiable service for a minimum of 16 minutes. So what makes it separate and identifiable? Well, the basics are that you're not talking about medication, medication side effects, compliance, choice of medication, safe use of medication. You really have said something to your client like, hey, okay, so it sounds like you're pretty stable on your fluoxetine. We have 20 minutes left, and maybe we could use this time to talk about some of the other stressors going on in your life. How would that be for you? Where would you like to start? So there really should be kind of some kind of transition or obvious place where it's clear you are really focusing on add-on psychotherapy. To be a separate service, it is supposed to be medically necessary, right? If someone is paying for it, they want to make sure that there's a reason for this, which you just need to kind of say, 17 minutes of CBT focused on clients' anxiety, which is contributing to insomnia and challenges with completing schoolwork. Okay, you've said that that's medically necessary. Boom, you're done. You've done it, right? It should be documented in a separate space in your note. It should not be documented in the same section as your HPI. I always encourage my mentoring clients to think about who is reviewing this note. It is a 34-year-old stressed out woman with 3 kids, 2 of whom are sick. One was late for school. She's pissed off at her husband that day. Make it easy for her. Have your HPI, and then underneath it somewhere say add on psychotherapy note. 17 minutes of blank kind of documentation. or sorry, blank kind of intervention focused on these target symptoms, which are impacting the client in this way. What is our goal? That's it. Make it easy for them. And so as long as you are fitting within these guidelines, you're probably good that you are providing add-on psychotherapy. It does not have to be provided in consecutive minutes. It can be integrated within a visit. That's fine. Um, you do probably still need, though, to just lump the total time together, but it doesn't have to be provided all together. If you guys have questions about that, we can go back and answer that after. Before we go into the kinds of therapies, I want to kind of show you this too, which is important in that it shows that the biggest things that affect change are one, extra therapeutic change, completely outside of your control. This person's family, their church or synagogue, their school, their community, their health, right? And technique is important, 15%. You do need to know something about DBT, some CBT skills. You do need to know how to do that. Expectancy means that client is there. That's why I was saying they showed up. They're in a health seeking space. Let's give them what they are there for. They expect something. And 30% is those common factors. It's, do you approach them with genuineness, care, positive regard, build an environment of trust? This slide, which is overwhelming, I just wanted to show you briefly that these are all different, these three slides. They show different kinds of psychotherapies and different diagnoses of how they can be applied. The reason I'm showing you this is I want you to see that different kinds of therapy can be applied to a variety of different diagnoses. And what's important is that we're looking at the person in front of us and targeting what we do to who they are and what they need in that moment. There is no, like, you're not going to do CBT if someone is super disorganized, hates homework, doesn't in general want to really think about stuff outside of your session. Then CBT isn't a right fit because CBT kind of demands that our clients do some journaling, some thinking outside of sessions, right? But maybe with someone who's depressed, even though CBT might be appropriate, maybe for them you use more ACT, acceptance and commitment therapy focus. So I'm not going to spend more time on this. This is available. Google it, but the point is multiple kinds of psychotherapies can be applied to different diagnoses. There is no, you can only use ACT with depression or something like that. All right. So let's deep dive now. We're going to spend like 5 minutes on MI, 5 minutes on CBT, just to equip you with a few skills and give you a taste for what you will get more of in either Lindsay's full boot camp or my psychotherapy toolkit. I can't remember exactly what she called it. Either course, this will kind of whet your appetite for what is available. Motivational interviewing is a really incredible approach to therapy for people who are focused on behavior change. If you have someone who indicates to you, oh my God, I need to cut drinking, I got to lose weight, I got to quit smoking, I need to change my eating habits, that's your little mental cue. When you hear change talk, that's your mental cue that, oh, motivational interviewing might be really appropriate here. Motivational interviewing, what I like about it is it's a spirit, it's not a script. So MI kind of is the idea of helping our clients recognize what they want, but it doesn't make us say certain things in certain order or memorize certain thought patterns or things like that. MI has 4 general kind of spirits to it. One is engagement. It says we need to engage our clients, that we're going to be their partner in helping them reach their goals. The medical model of, yeah, you really got to cut down your smoking because you've had pneumonia 3 times in the last year, is the antithesis of motivational interviewing. Motivational interviewing says, what's making you think about quitting smoking? And then the person says, I've had pneumonia 3 times in this past year. Why do we want it to go that way? Because people believe what they hear themselves say. If I say you need to quit smoking, you need to quit drinking, you need to lose weight, nothing. If I say, what's important to you about your health right now? What have you been thinking about? And they say, I've been really thinking about trying to switch to a little bit more of a whole food diet. Wow, what makes you say that? Well, I've been reading about how that can affect migraines. Ah, so migraines have really been holding you back from the life that you want. Yes, migraines are really getting in my way. Okay, I let the client have the best lines. Did you see how, like, really subtly, it's the client who said, I want to make this change. Here's why I want to make it. Here's what's important to me. I could have said that you got to quit eating all that shit junk food because, that's causing you migraines or whatever. But that's not MI. So MI also says, I want to evoke their reasons for change, right? I need to cut down on my drinking. What makes you say that? Well, my girlfriend's getting really pissed off at me. Okay, well, I just looked at your health records here and your liver enzymes are way off. I think that's why you need to quit drinking. Woo! I just lost this person because I want to evoke their reasons for change. So I'm asking questions. Why is this important to you? What makes you think about doing this right now? How will your life be different if you make this change? These are all examples of questions to ask to evoke their priorities. The concept of roll is rolling with resistance. We won't get super into that this evening, but at some point in behavior change, someone's going to say, yeah, I don't think I can do that. I just cannot. No, no, no. I ain't going to be eating no fish. No omega 3s for me. Not going to happen. Right? Well, we've got a couple options here. We can dig in and be like, no, you really need your omega 3s, at which point there's a disconnect. Or we can say, yeah, I can totally see that. Fish stinks. I get it. Well, okay, I've depowered that concept. I've depowered their resistance by not engaging with it. I've done what MI calls rolling with resistance. And then the last kind of MI step is empowerment, where we empower our client to make change by saying something like, have you ever made another hard change in your life? And they say, yeah, like a few years ago, I cut down on my coffee. Oh, how did you do that? It is so hard to cut down on caffeine use. Well, I did blank, 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 blank. So, how would you apply those skills to today's context, right? So, empower means we find strengths in our clients to empower them to move forward with change. MI also says, we as clinicians need to remember there's pros and cons of every behavior. And sometimes we try and deny that, right? Like the teenager, the young adult who's smoking marijuana every day, right? We're like, yeah, that is not working for you. But actually, it is working for them in some way, or they wouldn't do it. And MI says it's okay to say, so, what keeps you smoking pot every day? Do not be afraid to lean in. It's kind of like, don't be afraid of talking about sex to a teenager. It's not going to make them have sex, right? Letting someone say why they smoke pot every day is not going to make them smoke more pot. It's going to help them recognize, here's why I do it, but here's reasons why I don't want to do it. And let me sit and think about my values here and decide which way makes more sense. So MI says it is this conflict between I smoke weed every day because it really helps me shut out the outside world, right? But I also really want to quit because it's keeping me from reaching my fitness goals and it's bothering my relationship. And somewhere between these two things is my capacity to change, right? But I'm ambivalent because I really, really like that it keeps the outside world out. And so I'm not going to give that up, right? It's not going to be that easy. So as your clinician, I need to make that okay. And I need to say, yeah, pot is great in that it keeps a lot of the outside world stresses out. But I'm also hearing you say that while it's keeping the stress out, it's also adding some stress because you're saying you and your girlfriend are fighting about this a lot, and you seem to feel like maybe in some way it's holding you back from getting a job. Oh, the drug testing part. Yeah. Okay. So it's holding you back from getting a job. So it sounds like you're kind of stuck here. What are you thinking? Where would you go? So I acknowledge that. I acknowledge that ambivalence. And then again, I want that person to say, yeah, but I think at this point in my life, it's just not working for me anymore. The empower part of MI is where it does take some skill as a clinician to ask questions in a way that build up our clients. So think about if I said to you, like, why can't you change? I don't understand. I'm giving you a platform to tell me every roadblock that gets in your way. I don't want to do that. What I want to do is give you a space to say, how will your life look different if you're able to make this change? Because then you get to sit and tell me all the ways it's going to be different. You hear yourself say that. So instead of saying, like, well, what do you think is going to happen if you keep on, going about your life this way? I'm keeping you stuck versus if I say, what have you succeeded at in the past that might help you do this? What steps have you already taken in this direction? I am empowering, empowering, empowering. What makes this achievable for you? Right? So that's where our skill, that's where MI takes a little clinical skill is how do I ask questions in a way that builds up my client? Right? Here's a couple examples of those kinds of questions. Um, Scale questions. What scale questions do is they take this whole world of do I want something and they make us put it in a number. So I don't know, Lindsay, we can, if you are you able to respond, we could walk through this script really quick. Um, so Lindsay, how important on a scale of 1 to 10 is cutting down drinking for you?
I guess about a 4.
Oh, 4. So what keeps it from being a 0?
Well, I'm on probation, and truthfully, I'm getting too fat.
So how do you see things being different when you cut down?
Well, I'm hoping my parents back off. Um, and my friends have been giving me a hard time, but I'm hoping I'll feel better.
Yeah. So where do you see yourself starting this process?
Maybe going home more on the weekends, maybe cutting out Thursday happy hour and just doing Fridays and Saturdays.
Yeah. But you said it is hard not to hang out with your buddies all the time, and we got to honor that. I don't think you're going to give up on something you really like. So what's going to help you make that happen?
Well, I could tell my girlfriend to make me to kind of keep me accountable and probably put some reminders in my phone. Could try
Yep.
that.
So a couple skills here I was using. The scale question, it gives us a place to start. And your follow-up question, even if the person had said 1, hopefully they don't say 0. If they say 0, then MI is not the right intervention. If they literally have 0 motivation for change, just don't waste your time. But if there's anything there, then what keeps it from being a 0? Again, it puts them in the driver's seat of why do I want this change? And then you see, I asked, I empowered. Where do you see yourself starting this? What's going to help you make this happen? I really wanted this person to keep talking that through. Um, the take a step question, we don't have to role play this whole one, but the idea is this person is saying, I don't even like, I'm supposed to gain weight, but I don't even know how I'm going to do that. Right. So I'm asking, what would one step look like? Right? What would one step look like? And this young woman who's trying to gain a little bit of weight says, maybe I could try 100 extra calories. Maybe I could put guacamole on my toast. Right? And then I'm going to ask, okay, how would you do that? She says some photos. Tell me about the photos. Where are they? Okay, how are you going to actually get this going? Right? So take a step questions can be very empowering for our client. The last kind of question I think is really helpful is what advice would you give? So the other day I had a client and she had reduced her alcohol use from 3 bottles of wine a night to 3 bottles minus 1 glass. And we had been working on this for quite a while. And so she came in and she said, I poured 3 bottles of wine out in a decanter, but then I took out one glass and I set it aside and I did not drink it. So, medical model, I could have said, well, that's great, but that's not going to get you, sober anytime soon, right? But no, that's not motivational interviewing. Motivational interviewing was like, oh my gosh, that is not easy. What advice would you give a friend who is trying to do that? You just went through that. You did that every night for 5 nights. What would you tell someone who is trying to do that? I feel like you could probably teach a class on that now. And I wasn't fake. Like it really is true. It's like she really did take a step and do something great. And so I think putting our clients in the position of being a teacher, a mentor, is a really great technique as well. So, are you using motivational interviewing? Here's questions to ask to kind of catch yourself. Are you focused on their behavior, their motivation? Or are you focused on yours? Have you asked them what makes this important? How's this going to look like? How did you decide this? What makes this the right time? Why is this important? How'd you come up with this? Um, are you spending most of the session with their ideas about how they're going to create change? Are you arguing or trying to convince them? No, I really think you probably need to cut down a little bit faster than that. And then they start pushing back. Like we're out of the MI model when we're doing that. Is this their plan? Have they decided on this plan? And have you built their confidence for change? Right. So, one of the biggest successes I had with this was also someone with alcohol, a lot of alcohol use, that was going to the refrigerator over and over again over the course of an evening and drinking the equivalent of like 2 to 3 6 packs of beer, and or 2 to 3 12 packs of beer. And it turns out that like he was kind of almost addicted to that habit of going to the fridge, just kept doing it, kept doing it, kept doing it. We identified that it was really important to cut down, why it was important to cut down, that he felt he could cut down by maybe 1 beer a night. And so we came up with a solution, which was put 18 beers on the counter on Saturday. On Sunday, put 17 beers on the counter. On Monday, put 16 beers, 15, 14. And it was kind of like kind of comedy, right? Like who's going to suggest that their client put all that beer out? But my client was going to drink all that beer. We were just trying to kind of break the habit of the fridge with an unlimited amount of beer to choose from. And he did that and it worked out really great because it was kind of like a joint idea. So MI, to kind of wrap up, the MI interview, the actual MI session, utilizes 4 basic skills. Open-ended questions. Help me understand how smoking works in your life. Help me understand how this relationship, kind of stays important to you. Help me understand what's important to you about this choice, why you're choosing it. And then it affirms it. I get it. You smoke for comfort. This makes sense, right? Again, like it makes sense that people use cocaine because it feels freaking great. So we can lean into affirming that for our clients. It doesn't mean that we have to that we're supporting their decision. It means that we're supporting that they acknowledge that it works in their life. Then MI reflects. So it says, okay, I'm getting that you do this because this really makes sense for you, but I'm also hearing that you're trying to change this behavior because you said you want blankety blank. So we are fostering that ambivalence. We're reflecting back that this client has a decision to make, right? And then we're using a really strong summary. So we're saying, it sounds like you like smoking, but it also sounds like you're trying to quit for this reason. You feel like these things are going to make it hard to quit, but you've also identified some really, really great support people. And I've heard you say that you're going to take this step and that it's going to look like this and that this is how you want your life to look in the future. Am I understanding that right? Do you feel like I'm kind of getting this? So MI really uses that summary to empower the client. All right. So if you have questions about that, throw them in the chat. We'll try and come back to that. But again, all this is flushed out a lot more through taking Lindsay's Super Duper Bootcamp or my psychotherapy class. All right. Boom. 5 minutes on CBT. Most of us feel really good about CBT because it's very commonly taught. When I'm introducing CBT, here's what I say. Imagine you and I are at an airport and we're both going to New York City for a wedding. And your thought in your head is, this is going to be great. I'm so excited about going to this wedding. I'm excited that I get away from my kids for the weekend. It's going to be so fun. And my thought is, I'm about to die on this plane. I'm going to die on this plane. So there happens to be a therapist in this airport who's running around, and she knows that these are our two thought bubbles. And she comes up to me and she says, you have this thought bubble that you're about to die on this plane, but can you please just calm down? Can you just start feeling calm and relaxed? How easy is that for me? Not easy. She says, okay, you have this thought that you're going to die on this plane. Can you just stop pacing and stop looking for someone to give you, Xanax in the airport? No, I can't stop behaving that way because I have this thought in my head that I'm going to die. Okay, what if I could help you change that thought? Not get rid of it. You're not crazy for having the thought, but what if we could overlay that thought with some other perspectives on this flight that might make you feel less, 100% sure you're going to die? Then could you change your emotion of fear and panic and your behavior of pacing and popping pills? Okay, maybe. So CBT says there is a relationship between our thoughts, feelings, and behaviors. And the assertion of CBT is that if we can change our thoughts, the others fall into line. So many different therapies are based on this, but that's kind of how I explain it to my clients. A couple main tenets of CBT are that when something happens, like an event happens, but that event doesn't particularly have any meaning until I give it meaning by telling myself something about it, right? So I'm in a room and someone laughs. Okay, there's nothing attached to that until I tell myself, I think they laughed at me because I did not a great job at this webinar. That's my belief. What's the consequence of that belief? Well, now I feel some shame and some embarrassment. And I'm going to bring that now to my interactions with my family tonight. I'm going to bring that to the next time I put on a webinar. I'm going to bring that to my mood the next day. Was it because someone laughed that those happened? Or was it because of what I told myself about the laughter? It was what I told myself about the laughter that causes the consequence. So CBT says, can we interrupt? Can we go between A and B and give ourselves some other perspectives on that so that the consequence is not the same? So Dr. Burns, who Lindsay said she took a class from, is one of the founders, like one of the main, initial people with CBT who categorize these thought patterns. Sometimes they're called thought distortions that keep many of us and our clients stuck in cycles of anxiety and depression. And in a CBT session with my 16 minutes, and I will spend time going through each of these kind of thought patterns. And I'll say something like, all of us do these. All of us do some of these some of the time. But some of us do some of these a lot of the time. And for some of us, doing these a lot of the time keeps us stuck in negative cycles. It might be all or nothing thinking, black and white thinking. It might be a lot of like, I shoulda, 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 shoulda. And then I'll sit with the client and we'll take some time, going through what of these resonate with you, right? And it's totally fine, by the way, to use even a book during a session with a client as part of your 16 or 20-minute intervention and use that and document that as add-on psychotherapy. Going through a workbook together, reviewing thought records together is totally fine. A kind of a pillar of the CBT-based intervention is this thought diary, which you probably can't read super well, but this is available on everywhere online. But it basically says, here's the situation. I'm getting on a plane. What's my feeling? Panic. What's the image that's causing that panic? Death. What are the facts that support this thought? And I'll say to my client, you did not pull this thought out of your behind. There is a risk of death, right? It's really important to normalize, yeah, of course there's a thought of death. So what are the facts that support this thought? Planes do crash. I have bad luck sometimes, and so it's probably going to be me. Um, I committed a sin last year. I mean, I don't know. Whatever evidence they have, write them all down. And then you go to the next column. But what is the evidence? Let's put this thought on trial. That's a phrase I use a lot. Let's put this thought on trial. What's the evidence that your thought, I'm going to die, is not 100% true 100% of the time? And that's where we really push for like these details like, okay, what percent of planes do crash? How many planes crashed today? How many crashed yesterday? How many times have you been on a plane that crashed? How many people do you know who've been on a plane that crashed? You know, how many times have you flown and had the plane not crash? How many times do you know people who've flown and had the plane not crash? So you're really like asking all these questions. Like if they said, I have bad luck, you're saying, well, how many times have you had not terrible luck? Did you survive yesterday? Did you survive the day before? Were you hit by a meteor yesterday? Were you hit by a meteor the day before? Right? So you're really pushing this. And then you say, all right, well, the thought you had that you might die is still there, but now you've overlaid it with these other thoughts. How might you rephrase that thought that you had? And let's say they say, well, I could die on this flight, but the chances are actually pretty low. It's more likely that I will arrive in New York for this wedding alive than dead. And then you ask them to re-rate their anxiety or fear. And even if it went from a 9 to an 8, even if it's still really high, you can say something like, so hold on a minute. In the 7 or 8 minutes that we were just talking, your anxiety just went down a whole point or two, right? But doing this thought record can take your whole add on psychotherapy time. This might be a whole 16 minutes. You might not even get through the whole thing. But basically, this is CBT. You're walking through this structured approach of assessing how thoughts affect feelings and behavior. And then you learn as a clinician skills to help your clients kind of change their perspective, reframe thoughts, to look at evidence, to another approach is ask a friend. If you told a friend that you were for sure going to die on this plane to New York, what would they say? Well, um, you can do what's called a cost benefit analysis, which is just asking, how's this working for you? Right? Like, what is this costing you? How's this helping you? How's this hurting you? Right? And I guess lastly on CBT, I would share what's called the downward arrow technique, which means that someone says, for example, Lindsay and I were talking before this webinar. I'm anxious. We're doing this webinar. There's a lot of people coming. So if I'm the therapist, I say, all right, so whatever, there's a lot of people coming. Well, I could fail. All right, well, so what? So you fail. What does that say about you? Well, it means I picked the wrong career. Okay, so you picked the wrong career. What does that say about you? Like, who cares? Well, then it means I'm probably going to be out of a job soon. Okay, so you're out of a job soon. Whatever. Well, then I'm going to be homeless. Okay, so you're homeless. What does that say about you? Well, it says I'm nothing. That, like, oh, actually, I know what it means. It means that what my parents said about me when I was little is actually true, that I'm actually not going to amount to anything, that all the choices I made in my life were wrong. Ah, okay. So you're saying that between you at 6:30 at night having some anxiety about doing a webinar, that there's about 5 steps between that and every life choice you just made was wrong and you're a failure in life. Well, if that's the case, no wonder you're worried about the webinar, right? And then we go back. That's kind of the downward arrow technique, is getting to the core belief under the fear. There's always something, right? I'm not good enough. I'm going to die alone surrounded by cats. I'm not worthy. No one likes me. These are the most common things. We're asking the questions to get to that. But then we go back with our client and we might say, are there any other possibilities? Right? Well, I'm going really fast here just to give you the idea, but well, the webinar could not go well, but I might learn from it and do it again. That's right. The webinar could not go well, and I have to go take a class on how to do webinars. Yep. I could end up losing my job, but maybe the job I end up with is actually a good job and I don't end up homeless. Right. So we're helping our clients find off ramps. Okay. I'm going to do just a couple more minutes and then I want to leave time for Q&A. Um, Actually, let's just kind of more skip to the end because I do want to leave time. Supportive psychotherapy um, is what most of us use a lot of the time. It means that we're really just focused on building the self-esteem of our clients, right? Building them up through the use of unconditional positive regard. So finding a strength-based approach for our clients and giving them a space to work through their stuff on their terms in a safe environment. So, questions or interactions that kind of reflect this might be things like even someone who just got out of jail for murder, right? What feelings or thoughts, kind of drove that behavior? And how are you doing now that you are out of prison? How has the adjustment to family life been? I realize it must have been so painful to go through that period of addiction. How have you handled that? How is that for you? In what ways did that experience help you grow? What strengths have you found through this journey? Wow, what would you kind of, again, that teacher, that self as teacher, what would you teach someone else about this experience? So we're validating our clients as capable of love, growth, development, right? And then we're asking them things like, how do you feel like that experience is preparing you to move forward? How would you use that experience to help others? What did you take away from that experience? These are all kind of supportive psychotherapy based interventions. All right. All of that was going to be available through your courses, but I want to just show you, I'm going to end with one um, sample note because I cover in the video and Lindsay covers in her course a lot about documentation, the nuts and bolts of using add-on psychotherapy. And this is an actual note, so you can see there's a spelling error, whatever, but it was reimbursed. But you're saying how many minutes of the evidence-based intervention I used, what symptoms did I target, what was the goal of this person gave a few more examples of really what they did, and then what indicates that this might be helpful, right? They presented this theory when they were discussing blank, but they said it helped with blank, and here's our follow-up plan. So, again, add-on psychotherapy, any investment you make in learning it, I feel like pays for itself, which is great. It's one of those few win-wins that is great for our clients and great for our practices. And yes, the 20-minute therapist is coming out in book. There'll be one version of it out, I hope, by the end of October, and then another in 2026 with guidelines very specifically focused on us, not therapy standalone, not medication management, but how do we use these things together in the real world reality of 20 minutes to do it all. So,
Awesome. Thank you, Debbie. All right, I'm going to share my screen and then we're going to take some questions. Let's see here. So, the add on psychotherapy playbook is basically the best of Dr. Debbie Granick's resources that I kind of curated, put together for you guys as a pathway of sorts to be able to start to implement some of this. So if you want to go deeper, I'm really excited to share this resource with you guys. It includes her 3.5 hour add-on psychotherapy masterclass. When I first heard that, like that was mind blowing to me. It was what I wish I had heard in school. Because again, it's just so practical, so practical. That course is amazing. And then it also comes with scripts. It comes with prompts to get you started, the basics of documentation and billing. It has just full example video demo, which is really cool, I think, and also some sample templates and notes. And so I'm excited because I want to, if you guys want to go deeper on some of this stuff, be able to offer you guys the add-on psychotherapy playbook for free when you sign up for the boot camp. And
And Lindsay, the add-on psychotherapy playbook also is approved for 4 continuing education credits, whether you get it within your course or as a standalone. If you choose to complete the quiz and whatever, you're sent a certificate for 4 CEs through the American Nurse Association.
amazing, amazing. So the add-on psychotherapy playbook is valued at $997, and we are going to offer it 50% off if you are already a boot camp member, or if the boot camp isn't for you, but you still want to go deeper with this psychotherapy content, then that is absolutely an option for you guys. One of the differences with joining the boot camp is we are going to have a live 90833 implementation lab. I have more coaches helping me now who are going to be doing some of the case consults. And so I'm excited to basically be able to help with the implementation of brief psychotherapy more so. And it's something I'm really passionate about. That's, why I did my doctoral project on it. So again, this is free when you sign up for the boot camp today. You have 24 hours to claim that, and it's just for you guys here on the webinar. The boot camp actually isn't even open for enrollment to the public, and we do cap the monthly cohorts. So I wanted to give you guys first dibs for carving out time and for being here. And again, those are our offers. And we also have a money back guarantee, you guys. If you attend 12 live coaching sessions, you complete the boot camp, Debbie's masterclass, Tempest lectures, our advanced diagnosis lectures, and you don't feel it added value to your practice, we want to give you a refund. We want this to be a risk-free decision for you, because we are here to support you guys and give you more tools to use for your patients tomorrow, because we know the reality is it's a lot of times back to back, and we have a lot of patients to see, and it's hard to implement new modalities. So I'm going to stop sharing, and we are going to take some Q&A. We had some good questions, Debbie. We had a question
Kind
about
of, I was typing one answer, but I'll just take them and do them verbally. It's probably easier that way.
oh, I see. Okay, yeah, the one about the high deductible that people were
Yeah.
concerned about.
I think we can add that, yes. I think it's reasonable to say to a patient in two one. One is because they might have to pay for it, but also because you only want to offer what someone wants. So you say to someone, thank you so much for coming in today. We did your intake. I feel very, you came here for medication because you decided that you want medication to augment your mental health, and we can do that. I also am skilled in the provision of psychotherapy, and there is good evidence that doing both together can even help you move more quickly towards your goals. However, I really want to give you what you want. If you're really just looking for therapy at this time, I can refer you to blankety blank blank down the hall. If you're just looking for medication, that's something we can do together, or we can integrate both together when you're here, whether or not you have a separate therapist. I do want to let you know that for some insurance companies that just have a copay for service, you wouldn't necessarily see any difference in the cost. But if you have a deductible, because we would be integrating two services together, there would be a higher fee. So I totally understand if you want to take between now and next time we meet and see what that would be, or if today if you would like to focus more on one versus the other. So I think it's really good to just be transparent, say what you feel comfortable that you can do both, and meet the client where they are. They might say, I think I actually just want to start with therapy. They might say, I want both. I think my insurance will cover it. It's fine. Or I want both, but let me check on the cost. Or I think I have a therapist, I see her every week. And when I have my meetings with you, I tend to do it during the workday and just have like 15 minutes. So let's just have this be focused on medicine. And that's great. And truthfully, just in doing that, you've honored client autonomy and been a great provider.
Awesome. And then do we need to add medical necessity here too, is one of the questions.
So medical necessity was on that slide. You do not need to necessarily write therapy is medically necessary for this reason. You can. It's not wrong to do that. But that also can just be part of what you're doing. Provided, 17 minutes of CBT to target this. because this client's symptoms, these symptoms are impacting the client in this way. If it's reasonably obvious that you're saying this is important and here's why, then you're good. You don't have to use the term medical necessity, but some people choose to, therapy, um, medically necessary at this time due to the degree to which anxiety is limiting their function at work. You could just have that be a sentence.
Okay, I like that. What billing tips do you have for self-pay providers for clients who submit super bills? I use 99215 for comprehensive follow-ups, 99213 for concise follow-ups, and 90833 for 16 plus minute therapy extension.
I don't totally understand why the difference of the super bill, but I will say this, you cannot use two time-based services in the same visit. So not add-on psychotherapy, any kind of psychotherapy is always a time-based service. It's always billed or it's always coded based on the number of minutes, with 90833 being 16 to 37 minutes, 90836 being 38 to 53, and 90838 being more than that, right? So, since you can't have two time-based services, and since add-on psychotherapy is always time-based, your E&M visit has to be coded based on your medical decision-making elements, and that has to be clear. So you need to be familiar with how do you write up, an assessment that demonstrates that, which is basically here's the number of problems, or here's like that required a prescription, or here's the data reviewed, or here's the risk. Um, so your E&M has to be very clearly coded based on medical decision making.
Okay, that helps. Do you have any ACT trainings that you would recommend?
So I don't have a specific ACT training I recommend, but I will say I do think that it's acceptance and commitment therapy integrates really well into therapy, like, into medication visits. I actually will in the next few months be posting a 1 hour shtick basically just on ACT. Um, I mean, I guess shout out to PESI to a certain degree. I think they have some pretty good ACT teachers. I've taken a couple ACT trainings through them that have been good. One that wasn't good. Um, but no, but I would just say I think it's a good modality to explore. And Lindsay's going to have you guys' email address, so you'll be notified when we post the course on that.
Are you finding that claims are being flagged or thrown out when you utilize
No,
908 frequently?
nope, nope, not at all. I don't know if that is different for many of you guys, but absolutely not. As long as it is documented in a separate section, that the number of minutes is provided. Some people write 16 to 37 minutes of therapy. That is incorrect. Write the number of minutes that you did it for. But if you follow the guidelines that are laid out in the course, which you could get, absolutely not. I would say 3/4 for sure of my visits have a 90833 because I schedule them all for half an hour and my follow-ups, and that's just my kind of typical, like that's my clients have come to kind of expect that from me. But no, I have not found that.
Are there any insurance companies that won't pay for Psych NP add-on therapy if they have a separate therapist?
I have not heard of that. I have heard of it not being reimbursed if someone gets therapy alone on the same day as E&M plus add-on psychotherapy. It was Medicaid and Medicaid that was being a stickler about that for a while, at least in North Carolina. I tell my clients, if you would like for me to sometimes integrate in some therapy, I would not come to me on the same day you come to your therapist. I just tell them not to do that just because it cuts down on that issue. But
Yeah.
no, in general, you can
Yeah.
have a therapist and get add-on like psychotherapy from your prescriber.
Awesome. And then what if 90833 is used infrequently but for the same patient in terms of clawbacks and reimbursement?
No, I think that the same patient can have that as part of their care, and that's almost always what is done when they are there. I will say you don't need a separate treatment plan for add-on psychotherapy. You do need a treatment plan if you're doing therapy alone. But what I do in my initial intake, if I'm doing an actual treatment plan, is I say treatment will include a combination of medication management and psychotherapy to help the client reach these goals or resolve these issues. I just put that down there once, so it's just there. But no, there's no limit on how often someone can get that service.
Awesome. When do you think it's important to make it clear to the patients that we are not trained therapists? For example, they need a therapist that can take them deeper.
So, first of all, many of you guys are trained therapists, right? And we have to remember that, look at your scope of practice questions on your nursing board website, which is basically like, would a jury of your peers feel that you're operating safely? Did you get some education about this? Have you had some training? Have you had some mentorship? Do you have some supervision, right? Have you taken some didactic classes in this? But I say constantly, and I'm a very experienced therapist, I say, in our visits, we have a brief amount of time. And I think that sounds like some of the trauma you're discussing from your childhood or some of the trauma from your military service is having a pretty big effect on different aspects of your life. And I want you to have time and space to explore that. I don't know that my office, where we have multiple things going on and we're looking at labs and doing medicine, is the best place. I think from my perspective, it seems like it'd be really nice for you to have a place where you have 50 minutes on a pretty regular basis to really work through some of these things.
Yeah.
Have you considered that? Would you like a referral to a therapist? So I really, first of all, I don't focus it on whether I do or don't have skill. I focus it on my, what I kind of want for them and what I've seen that could be helpful for them.
Yeah.
If someone says, "Hey, Debbie, do you know how to do EMDR? I've been having a lot of nightmares or something," I might say, like, I think I'd recommend someone else for that, both because they have more training and because they have more time in a session. So I would be honest if I was asked, but in general, my approach is to think of it from their perspective. What do I want for them, and to share that with them.
Absolutely. Okay, last question, and it's a really good one, Marie. Uh,
Uh-oh.
do they ever audit time? I'm a student, and every patient gets a 90833 add-on and a 20-minute appointment. And this comes up a lot where, new grads in my program are like, this is my job offer, and it's,
Uh,
minute med checks, and I'm expected to bill
right.
psychotherapy.
So first of all, I saw someone wrote in the chat, is the boot camp appropriate for students? And I would say 100% yes. And this is one of the reasons, because you get really great mentorship about job offers. But so the time of the visit does not dictate whether or not add-on psychotherapy was provided. What dictates whether add-on psychotherapy was provided was whether you and a jury of your peers would say that there was a very clear non-medication focused psychotherapeutic focus for at least 16 minutes of that visit. So I personally don't think it's ethical that you're being encouraged to do that. I understand there's a reality to everyone needs a job. But no, that really is not the spirit of the service. The spirit of the service is that, in addition to focusing on medication, you provided a more complex service during that time, and that separate service was at least 16 minutes long. So, a 20-minute visit, I mean, was 4 minutes enough to really gather all your elements for really good medication management? Maybe, but definitely not most of the time, probably. So, um, yeah, I don't love that. I don't love that for you.
Yeah. There is 3 more questions. Are we
Okay.
wanna wrap it, or you wanna answer those?
I missed the first three. Is there a replay? Lindsay, you can answer that. What if someone asks if we can just see them for an hour? Well, that depends on your practice, right? And whatever. And then, do you offer psychotherapy only appointments? So that is really up to you guys. And that probably is, if that fits into your life, your sense of skill set. Yes, the codes are different. So those are like 90834, 5. I'm not even remember. I'm sorry, because I don't bill those. I don't do those. But yes, you can do psychotherapy only appointments. You're leaving money on the table if during those appointments you even check in about the Prozac, right? If you even check in about that a little bit, you should be billing like a 213 or something like that, and then doing add-on psychotherapy. But if you want to just do psychotherapy visits, absolutely. They're all time based. And the documentation is a little bit different, just a little bit higher expectation for flushing things out, but absolutely.
And then, so if no treatment plan is needed, how specific with goals do we need to document using like the SMART goals format with the measurable goals?
So in an add-on psychotherapy, not. There is not the expectation in an add-on psychotherapy note that you are doing that. So I am generally just pretty vague, like, goal is for client to, increase their sleep from, 5 to 8 hours over the next few weeks, or goal is for client to feel like to practice meditation daily, goal is for client to get to work on time. So I'll usually put something measurable, but it's more also because when my client comes in the next week, or not, probably not the next week, the next month, I'm going to say, so last time what we decided on together was this. How'd that go for you? Did you try it? Did you not try it? It really gives a great intro to the next add-on psychotherapy session.
Awesome. Awesome.
So,
Uh, Thanks, Molly, for being on. Appreciate
and
it.
then someone said, can we purchase the program now and start later? I can speak for my program, Lindsay, which is when you purchase the program through Lindsay, it's lifetime access. It sits like you will have a login forever and you can log in forever and do it whenever you want. I don't know if there's live aspects of your boot camp that um, people, if they buy it today, that they're in a cohort that starts.
We do make some exceptions, so just reach out to us as far as like a delayed start date, where that makes sense. That's we have a year of support in the boot camp, and that's part of why, because we understand that life gets crazy busy sometimes. Sometimes you're like really intensely studying for boards, and then you'll take advantage of like the live coaching, the case consult, the peer support, maybe a few months down the road. So just reach out, okay?
Yep. I
Um,
do I do want to say also really quick that Lindsay and I came together to do this because we really do believe in this work, and we're so so glad that you guys showed up, that you believe in this work. It is 100% what's best for our patients, what's best for us, staying in this practice, feeling that what we're doing is rewarded. I will tell you guys, I mean, Lindsay's a better marketer than me, but we would be so appreciative of you guys giving a shout out to this program in your social media networks. People do not have to have attended the webinar tonight to get the discounted course. So if you have a colleague or friend who you think might be interested, please pass this on. And also, if you guys have any feedback on this, please, I don't know how they should write that, like on to get that to you, Lindsay, but so we can keep doing this and make it better and better.
I think Ryan will send out a follow-up
Okay.
getting feedback, because yeah, that's why we're here, you guys, is really to get your feedback, hear what's helpful. I know the feeling of like reading all the available psychotherapy resources that are kind of geared towards prescribers and not feeling like it's stuff that you can implement. And that was just super stressful for me. I did read Kathleen Wheeler's book front to back. Not that it's not a great book, I just still felt really overwhelmed with
Right.
what to say. I don't know.
Right.
Just yeah. So I really
Right.
love that it's actionable. I feel like Debbie does a really good job, like Dr. Carlat does, in terms of making resources that are you can implement tomorrow. So yeah, the boot camp is helpful for people who have been practicing a few years. Absolutely. Thank you guys for being here tonight.
Yep.
And
And Ryan's going to drop. Someone asked about just getting the link to get everything. Ryan will send that, or for people to.
yes. Wait, hold on. Let me see what it says.
Someone just asked for the link to go to purchase.
Okay. Okay. Got it. Got it.
We'll make sure everybody gets that.
Um, Yeah. So yeah, Debbie's like, she really is like the thought leader in this space. I'm extremely excited about her book. Um,
Me
and
too.
yeah, she used to, I mean, she offers as much as she can. She gets a lot of like consulting and speaking gigs. She's diversified her revenue streams, you guys. I mean, how smart that even this master class was her doctoral project. Really, really cool. So yeah,
Yeah,
she'll
and if any of you guys work for places like, especially that place that wants everyone to do add-on psychotherapy, if any of you work for places that you think would be interested in having me do a training, I would be so happy to talk to you or your manager about coming and doing a training for, like an onboarding about how you kind of do this together. Um, the more of us who are practicing this, the better it is for our patients. So hope everybody
Exactly.
has a great, great night.
Thank you guys for being here. And yes, we'll follow up via email. Okay. See you guys later. Thank you.